Welcome to the Spotlight on Medication-Assisted Treatment. My name is Anjali Nandi, and I will be your host as I walk you through an understanding of addiction, opiates, as well as what can be done to support people with opiate addiction. Over the past 20 years, I have provided treatment services for folks struggling with addiction, as well as those in trouble with the law. I also serve as a consultant to criminal justice organizations, human service entities, and treatment providers. The Center for Health and Safety Culture, sponsoring this video, is an interdisciplinary center serving communities and organizations through research, training, and guidance to cultivate healthy and safe cultures. So let's get to it then. In this spotlight on medication-assisted treatment, we will start by developing an understanding of addiction, opiates, as well as what can be done to support people with an opiate addiction. We will cover some of the common medication-assisted treatments that support recovery, how and why they work, and we will end with a brief conversation about some common concerns related to medication-assisted treatment. So let's start by understanding the neurobiology of the brain. In order to truly understand addiction, this is where we need to start, because fundamentally, addiction is a disease of the brain. Our brains are made up of two primary systems, the limbic system and the frontal cortex. The limbic system is our old brain. It is responsible for things like emotions, reactions, our survival. It matures early in life and it houses our reward circuitry. Our frontal cortex is responsible for consequential thinking. It allows us to think through problems, to think through pros and cons, to make complex decisions. It is responsible for our executive functioning. This reward system that lives in our limbic system is implicated in addiction. And the key neurotransmitter that's involved in addiction is called dopamine. So essentially, in order to survive, we need a few things. Of course, we need air, we need food, we need water, and interestingly enough, we need dopamine. Dopamine is a chemical that provides us motivation. It also gives us the feeling of love and connectedness, feeling like we belong. It gives us a sense of confidence, and it gives us the motivation to really do life, to get out of bed in the morning. So on average, we need about 50 nanograms per deciliter of dopamine in order to get out of bed and function in our daily lives. On our best day, we might have 100 nanograms per deciliter in our bodies. Our best day might look like experiencing something that we really have been looking forward to, having a glorious day, maybe even winning the lottery, where we're on top of the world. That's about 100 nanograms. Incidentally, eating our favorite foods that we really love and crave and enjoy, produce about 90 to 95 nanograms of dopamine in our bodies. So that's our range, somewhere between 50 and 100. When you try a substance such as alcohol, heroin, or meth, the amount of dopamine in our bodies skyrockets to about 10 times what we need. Using drugs can take the number of nanograms per deciliter in our bodies to about 1,000. You can imagine the euphoria then that you feel from the use of alcohol or drugs. But the problem is your body is out of homeostasis. Homeostasis is the range in which your body can normally function. So homeostasis is this sort of normal range. And when you're out of this normal range, your body has to fight really hard to bring it back into normalcy. So let's say every time you consume substances, your body gets out of normal, meaning 1,000 nanograms or something pretty high. Your body over time will start to make adaptations so that you don't get so far out of normal. Some of the adaptations are killing receptor sites that normally would have absorbed or would have experienced whatever the drug is that you're taking. It might even reduce its own production of certain neurotransmitters, and dopamine is such a great example. So your body will then naturally stop producing dopamine or produce low levels of dopamine because it knows that dopamine will be coming from some external source. So addiction then is a treatable brain disease. It is chronic, which means it is persistent and recurring. And we relapse. That's one of the defining features of addiction. Let's compare it to diabetes. Interestingly enough, relapse rates in addiction are very similar to those relapse rates with diabetes. Diabetes is a chronic disease of the pancreas, while addiction is a chronic disease of the brain. Addiction is characterized by craving and seeking the drug, really needing the drug. This seeking behavior persists despite some very negative consequences. Just like with diabetes. Someone with type 2 diabetes will indulge in foods that are harmful to them. Just like someone with an addiction will seek the substance despite some pretty severe negative consequences. Now you might be thinking, wait, I didn't choose to get diabetes, and someone who is addicted to substances chose to use. So let's think that one through a little bit. Even with something like type 2 diabetes, there are things that I can do to prevent me from getting type 2 diabetes. I can clean up my eating. I can work out. And yet, if I don't do those two things, let's say I eat a tremendous amount of fatty foods or foods with high levels of sugar in them, I can shift my body's neurochemistry to where I develop type 2 diabetes. So there are certain behavioral choices then that I'm making, just like with addiction. And interestingly enough, people tend to use substances and get addicted to substances long after they feel good from them. It moves from just feeling good to survival. So there are a lot of behaviors that we seek or indulge in, but it becomes an addiction when this behavior is harmful by some acceptable standard. And it's an addiction when it's diagnosable as a substance use disorder. There are several levels of a substance use disorder. It can be mild, moderate, or severe. So let's get really specific then and talk about opiate use disorders. Opiate use disorders are a chronic disease of the brain related to the use of opiates. There are essentially two kinds of opiates. There are prescription drugs, and then there are illicit drugs. Illicit drugs like heroin, prescription drugs like oxycodone, hydrocodone, codeine, fentanyl, morphine. All opiates, though, whether legal or illegal, they produce pleasure and relieve pain. They relieve pain by binding to specific receptor sites in the brain, in the spinal cord, and in your gastrointestinal tract to minimize our perception of pain. Opiate use disorders are more common than you might think. In 2017, opiate use disorders affected over 2.6 million Americans. About 2 million Americans are addicted to prescription drugs, and a little over 500,000 are addicted to drugs like heroin. Unfortunately, a considerable number of drug overdoses and deaths are related to opiate use disorders. Drug overdose is the leading cause of accidental death in the U.S., and over half of those drug overdoses can be contributed to opiates alone. An overdose occurs when you take enough of the drug that your breathing and heartbeat, and this is specific to opiates, slows down or even stops. Oftentimes people ask whether people who start using prescription drugs then move into heroin use, and that is absolutely true. About 4 in 5 heroin users started by misusing prescription painkillers and then moved on to heroin use. So let's talk about some of the challenges when it comes to opiate use disorders. One of the challenges is an increase in tolerance. Tolerance is the amount of the substance that you need to take in order to have a particular result. Tolerance increases when it takes more of that substance to get the same result. So with opiate use, it might take more and more opiates to get me the same result that I'm looking for, the same pain relief or the same pleasure sensation. Let's say I stop using opiates. I will experience something called a loss of tolerance. However, I don't know exactly how much my tolerance has reduced. And therefore, let's say I go back, because addiction is a relapsing disease, and let's say I relapse and start using opiates again. The danger is that I might use enough of the opiates that wouldn't have caused me a problem back when I was using regularly, but now could cause an overdose because of this loss of tolerance. So I might experience an overdose even at an amount that was no problem for me in the past. With opiate addictions, relapse rates are high. When providing counseling or behavioral therapies alone, unfortunately, relapse rates, even after a year of treatment, are sometimes as high as 90%. These relapse rates can be cut in half when medication is added to treatment. So combining medication and treatment is the most effective way of treating an opiate addiction. This is especially true for folks with limited social support and stability, those who've experienced trauma, or those who have had adverse childhood experiences. So if you think about opiate use and addiction, we can overgeneralize the folks who get addicted and put them in two camps. One camp would be folks who have an extensive support system, a support system that's really rooting for them as they're in recovery, a support system that helps provide access to health care or counseling. These folks recover really well from opiate addictions, even sometimes without the use of medication. In the second camp, we have people that have limited social support, limited stability, or those who've had really tough childhoods where their brains have been impacted enough at a really young age that they're not producing the levels of dopamine that we've talked about earlier. It's these folks where relapse rates are extremely high, and it's this population where combining medication and treatment is really the most effective way of treating an opiate addiction. And I hope this also explains why family members and social support are crucial in addiction support and recovery. So let's clearly define what medication-assisted treatment, or MATs, are. Medication-assisted treatment is using a combination of medication and counseling or behavioral therapies, such as cognitive behavioral therapy, for example. And as we talked about earlier, medication-assisted treatment is more successful at treating opiate addiction than using counseling or behavioral therapies alone. The two most common substance use disorders that are treated with medication-assisted treatment are opiate use disorders and alcohol use disorders. This is for a variety of different reasons, but both opiates and alcohol have tough withdrawal processes, both difficult and potentially dangerous withdrawal symptoms. Let's talk about the medications for alcohol use disorders. Some of the medications that are used to treat an alcohol use disorder are disulfiram, naltrexone, and acamprosate. The brand names for these are Antabuse, Vivitrol, and you may have heard of Camperol. Antabuse or disulfiram works in a really interesting way. What it does is it causes a physical reaction in the body when alcohol is consumed. So it doesn't really reduce symptoms of withdrawing or craving. But what it does is when somebody takes a drink, they will have a really negative physical reaction to it because of Antabuse or disulfiram. Naltrexone, on the other hand, works really differently. What it does is it blocks the receptors that are sensing that feel-good feeling from alcohol that we get. So these receptor sites are usually involved when drinking or craving, and naltrexone blocks these receptors, so drinking doesn't feel as good, and craving is reduced. Camperol balances some of these neurotransmitters that we're talking about. So in addition to balancing dopamine and supporting dopamine, it addresses GABA, which is another type of neurotransmitter that's involved with alcohol use. The medications for opiate use disorders work in some similar ways and some slightly different ways. We've already talked about naltrexone. Naltrexone is an opiate antagonist, which means it blocks the effects of opiates, if opiates are used. Methadone, on the other hand, is quite different. It's a full agonist, meaning that it mimics the actual opiate drug, meaning it's similar enough to that it provides some of the euphoric effect, but it minimizes the symptoms of opiate withdrawal and then blocks any additional positive effects if I use heroin or something similar to heroin with methadone. Buprenorphine is a partial agonist, So it doesn't completely block the receptors, and it has a ceiling effect, which means there's a ceiling, there's a cap to how good I feel. I can only feel so good on buprenorphine, and then I can't get to that euphoria. So it doesn't produce the same amount of euphoria, and it doesn't have the same dangerous side effects that opiate use does. You can also combine buprenorphine with something called naloxone, and that is sold as Suboxone. By adding naloxone, it reduces the likelihood that the substance can be abused because naloxone has a really low abuse potential. I'll talk about naloxone a little bit more later in this spotlight. I'm sure as you're listening to this, you have a lot of questions. I wanted to take a minute to address some of the common concerns that usually come up. People often will ask, what is the difference between providing a medication and just using the substance? Aren't we substituting one drug for another? This is a great question. Sometimes people would even ask, wouldn't people who are given medications just sell them to fund their drug habit? So I want to take a moment to address some of these concerns. The difference between providing a medication or using the actual substance such as heroin or hydrocodone is both intensity, meaning intensity of the high that you get, the euphoria, as well as the effect. When using something like methadone or buprenorphine, it doesn't just substitute one addiction for the other. When someone is treated for an opiate addiction, the dosage provided doesn't cause them to get high. It reduces cravings, and it also reduces withdrawal. This allows the person to balance their brain circuitry. It also balances dopamine that is so terribly damaged when recovering from addiction. It allows the person's brain to heal so that behavioral therapies or counseling can take effect or work. One of the interesting effects of dopamine is in memory and learning. Without dopamine, we cannot onboard new memories or onboard learning. And so without dopamine, when somebody's sitting in a behavioral therapy trying to learn new skills, they're actually not able to hold on to these memories because of low levels of dopamine. And so what these drugs, methadone, for example, or buprenorphine, what they do is allow enough support of dopamine so that behavioral therapies or counseling can actually work. And then this question about whether people can just sell their medications is a really good one. People in the field often refer to this as diversion. Are people able to divert their medication to sell them on the street? It's actually really uncommon because, for example, with buprenorphine, there's stuff being added to the medication that reduces its abuse potential and reduces the likelihood that it's going to get diverted. So what can we do? Maybe that's what your brain is thinking now. What can we do? Perhaps as family members or as a social support system for those at risk for opiate addiction or opiate overdose. Well, one of the things you can do, you're already doing, which is listening to the spotlight on medication-assisted treatment. Another is to explore and make sure that folks have access to treatment for addiction in general and opiate use disorders in particular. Also to increase the use and the availability of medication-assisted treatment, given the evidence that says that medication-assisted treatment really supports behavioral therapies and counseling to work. We could also increase the access to naloxone. I know I mentioned naloxone earlier. Naloxone is an antagonist, an opiate antagonist. What it does is it reverses the effect of opiates. And so particularly helps with reversing the effect of opiates on breathing. So it allows the person to breathe again. And when naloxone is given in a timely manner, it can prevent deaths from overdoses. So having naloxone available could really save people's lives. It has a low probability of abuse and it can be administered by a lay person. So let's summarize what we've talked about today. We started with an overview of addiction, and we talked a little bit about the brain, about the limbic system and the frontal cortex, and the importance of dopamine. We also talked about how important dopamine is to survival and the impact of addiction on dopamine. We talked about several different medication-assisted treatments and some specific medications that are used for alcohol and for opiate use disorders. We talked about some of the concerns that come up frequently, and we ended with some ideas of what you can do. I want to close by just providing you with some resources that you can access if you would like additional information. Thank you so much for taking the time to listen to the Spotlight on medication-assisted treatment.